Hello, and welcome to another episode of the Scopewell podcast. Today, I'm joined by Dr. Juan J.C. Rojas, Associate Chief Medical Information Officer at the Rush University System for Health. So today you work at the intersection of frontline medicine, data science, and AI. Before we get into everything that you're leading, can you walk listeners through your journey into healthcare and what you do at Rush?
Sure. My journey, I think is maybe not dissimilar to a lot of other people who got into medicine. At an early age, I sort of found a passion for, science and biology, and sort of thought through, what are some careers in which I can apply some of that scientific knowledge I really think is interesting, and learn more about, just not just humans, but, animals and all the things that are going on in the world when I was a kid. And then, I was fortunate enough to grow up in a household that had, two really loving parents that were really supportive, of, whatever I wanted to do in my career. And my father is now a retired, physician. He was a heart doctor in the Metro Detroit area for, something like 40 something years before he retired. And so I did have sort of a role model, I guess, at home, but certainly I think we've taken different journeys, even though we're both in the big circle of medicine. I think we've taken very different roads, if you will. And so for me, it was really that light bulb moment that you could sort of combine, your passion for just working with people, and then applying kind of that science or biology background, and then that's sort of what drove me to medical school is the combination of the science behind medicine, but also I think the art of medicine, which people sort of say is the people part, right? And I think even now where we are today, as far as how AI may augment the patient-doctor relationship, I think the part that's more human or humanity, I think is going to be even more important as we sort of go into this next 20, 30 years of medicine.
And can you touch on your current role just at a high level?
Sure. So I am currently the Associate Chief Medical Information Officer at Rush University System for Health in Chicago. And so in that role, I spend a lot of my time thinking about kind of AI innovation and research that helps support the mission that our health system has, which is around great patient care, producing world-class research, and really investing back in our community with a huge focus on health equity as one of the core pillars of the organization. And so a lot of the work I do, both within the Office of Informatics, working with our Chief Medical Information Officer, Dr. Bina Desai, and now also working within our BMO, Rush BMO Institute for Health Equity as the director of this new data analytics studio that we set up in the last year. I'm sort of kind of trying to find my way to contribute to those three different parts of the mission: the clinical care when I'm, wearing the doctor hat, the research mission for helping researchers get better, higher quality data, and also doing my own research. And then also really trying to advance the equity mission that we have at the organization to find ways to close or mitigate health disparities that exist within our own walls. But even now, more broadly speaking, trying to find ways to close those gaps outside the walls of our traditional health system and more in the community in the Chicagoland area.
Thank you so much for that context. Let's talk a little bit more about the Health Equity Data and Analytics Studio. What was it built to address and how did it come together?
Yeah. So essentially, it was built to address really one core problem that we hope to contribute to the solution, I should say, which is the known death gap here in Chicago. So this is not dissimilar to other urban areas, but certainly something that has been well documented in the Chicago area. It has been getting generally better over time, but still is persistent. So as of the last year, there are communities in Chicago that are roughly 2 to 3 miles from each other as a crow's fly, if you're just flying directly like a bird. But then if you look at what their expected life expectancy is, those differences between neighborhoods could be as large as 20, 22, 23 years, in the past, even as high as 30. And so what we are really focused on as a studio is how do we think about ways to mitigate health disparities that are contributing potentially to that life expectancy gap, and kind of doing stuff, but within our own walls to make sure that we're doing right by our patients at Rush that we are seeing every day in our clinics, our hospitals and emergency rooms, but also trying to think of how can the studio, as an entity of like-minded people who like data, who have a passion for working with healthcare data, and also have a passion for really our mission at Rush around health equity as being a core pillar of our mission. Then how do we think about applying that, to other organizations, whether that be clinics we work with that send us patients, or community-based organizations that serve our patients, like food pantries, shelters, etc. And so I think that's what we really were thinking about when we set up an organization. We were like, well, do we need to exist? Like anything in any organization, you always want to ask, is there a reason for us to exist? And we sort of felt like we had this right sort of niche where we could apply our data analytic expertise as a team for specific high value things that we're working on as an organization at Rush, kind of applying what we're calling an equity lens to problems to make sure that we sort of dive below the surface. And, sometimes something might look like it's really doing really well, but if you dive beyond the surface, patients may have varying levels of success. One maybe will be going up by 10%, but maybe the other one's flat at 2%. So why is that? Can we drive it to the data and then create a plan that might lead to sort of action or improvement for those patients that aren't maybe doing as well as the others? So we're trying to do that both locally, and then now trying to also do that in a more collaborative way with other engaged stakeholders across the city from a researcher, public health, or government point of view.
So one of the outcomes of that work that you're describing was the recently launched Chicago Health Map. For listeners who aren't familiar with it, what is it and what does it allow people to do?
Yeah, we're really excited and proud about this being kind of our first sort of public-facing tool, if you will. So the Chicago Health Map project, so at chicagohealthmap.com, for those of you who want to visit it, is really our first foray into this kind of idea of data to action. In my time as a physician working in data, what has been very apparent to me is that for a variety of legitimate reasons, mostly patient privacy and competition, healthcare systems typically sort of have their data live in islands. And we figured, okay, well, we know that in Chicago, we have 5 to 10 large health systems that care for the vast majority of people that are in the Chicagoland area. Wouldn't it be nice if we could partner with a data partner that could provide us with data to better understand the health of those patients without in any way disrupting privacy? And so we were fortunate enough to work with a research-based organization called CAPriCORN. And CAPriCORN is a research network here in Chicago that has been around since around 2014 or 2015, that was sort of stood up by investigators, with the lead investigator being at Northwestern, Dr. Abel Coe, but now is a kind of consortium of investigators who work together collaboratively on sort of shared research projects across the Chicagoland area. And so a lot of the health systems that we were interested in maybe partnering with already were in this network. So I went over there and made a phone call to Dr. Coe and sort of said, hey, this is my idea. What do you think? And we had some legitimate research questions we're still trying to answer now with the data we got. But we also said, if we're going to get that data, would it be okay if we also turn this into a public resource, a map? And so what the Health Map project has evolved into is for those health systems who are contributing data to CAPriCORN, we are now making that more available publicly, where we can say, if someone has high blood pressure in somewhere in the middle of Chicago on Main Street, Chicago, can we take their address and sort of say, in 2019, you saw a doctor at, Rush, and the doctor said you had high blood pressure. Now we're able to sort of say, you are one person in 2019 who had high blood pressure in that geographical zone. And we were able to then take that address and map it to the census-tract-level, which is a really small unit of analysis. That's like 1,500 people, often 2,000 people in a city sometimes, and sort of say how many people in that little circle of the world have high blood pressure. So that way we would get a better sense of what we're sort of thinking about as sort of hot zones or blue zones. So areas that are doing really well, and what can we learn from them? And areas that are having more disease for a variety of reasons, and sort of figure out if we can deploy resources with local partners to those areas to then sort of say, okay, can we start seeing some signal of improving, say, the high blood pressure, the diabetes, the high cholesterol in that area? And the reason that this is important is that historically, we on the public health side, the way that we used to historically get that data was going into the community saying, hey, this is in Lincoln Park, Chicago. We're going to just do a random survey of people that are, walking down the street, if you will. Hey, did your doctor tell you you have high blood pressure? And the answer would be yes or no. And we would use those estimates to get a sense of how many people in that local area have this condition. What we decided to do was the reverse. How many times did the doctor tell you you have high blood pressure, whether or not you remember it or not? And so it's a different pro and con. Neither data is right or wrong. It's just different. And so what we wanted to do was to sort of take that condition data that we generate as health systems and represent that in a map where we could better understand the health of our community.
So what you're describing is a situation where a lot of it was self-reported, and now you're getting like kind of cleaner data. Social determinants of health has been a hot topic for many years. Do you feel that better data is like a missing piece for us to address that?
Yeah, I mean, I think it's one big part. I mean, we do know, from studies that now have gone back 10, 15, 20 years that probably the biggest driver of healthcare outcomes are actually your social needs and less your genetics or your biology. And so those often intersect with each other for different reasons, but often those are a big driver. And so to your point, I think one of the things that we haven't done well in people who are thinking about population level health in urban areas or rural areas is really get a sense of where are the diseases centralized and where are people really the most sick that could benefit from more help. We know that we have limited resources and we can't deploy a blood pressure van in every corner of the city to screen for high blood pressure. But if we knew the areas that had the highest rates of blood pressure, maybe there are other people in that community who have no idea they have high blood pressure. And maybe we can diagnose them and then mitigate the risk from high blood pressure in the future. And so I think this is one way. It's not the only way where you can say, how do we take data, have different partners, whether that be a researcher, aldermen here in the city of Chicago, who we know that for those of us who live in Chicago have a fair amount of power, if you will, and elected representatives, mayor, other people like that, who can take a look at the data that is available now and sort of help make more informed decisions. So that way we can deploy resources or make partnerships with local resources to sort of hopefully take this data and then drive it into action in some way. So that way, some of the big drivers we think for the life expectancy gap are really both heart conditions, metabolic conditions like obesity and diabetes. And so can we sort of use this data to then partner with people to then sort of start working in the community to sort of mitigate that on a really hyper local level, right? Like the census tract level is really unique. And we don't, historically, if you look at data like this, even if it was available, it was on like the zip code level. And for those of you who are listening who live in Chicago, you know that in one zip code, it could be very different. Like the top part of the zip code or the bottom part of the zip code could be totally different communities. And so while it's good for Mayo, it may not be good for health.
So you're describing a lot of different stakeholder groups that could use this tool in serving clinicians, researchers, policymakers, etc. Was it difficult building something that creates value for so many different audiences?
Yeah, I wouldn't say it was straightforward, certainly. I think the biggest thing that we were fortunate enough to do is two things. One, we were fortunate at Rush to receive a large philanthropic award from the Searle family, Chicago Community Trust by the Searle family. And so that is in part funding this mission around having a studio, having both an internal and external facing arm of the studio, with this health map project being really a center stone of the studio itself. And so we were lucky to have funding, which is, for better or for worse, really important these days for really doing anything. And then number two, we were really fortunate to have the CAPriCORN network and all the hard work that they have done.
So you've been working in this project for some time, and now that it's live, is there anything that has surprised you since all the data's come together? Were there any findings that maybe challenge your own assumptions?
I would just say I've been surprised that, the reception has been really positive. It's always nice to get feedback from people saying that this will be helpful and useful. I was at a meeting where we were doing kind of a pre-launch with a group of pastors here in the Chicagoland area who have a kind of a health faith-based network. And one of them actually said, hey, I can actually, use this to help figure out where I'm going to put some of the resources that we have in the church to sort of deploy locally. And so that was really helpful that, I heard that feedback that someone could really take that information, make that sort of exactly what we were hoping to do, which is sort of data to action.
And how do you know when you've actually made a difference? Like, what will tell you that you're creating a real impact?
I think ultimately for us, it will be really how do we feel like in the next 4 or 5 years as we have this project slated to at least continue through 2029, 28. Can we sort of see longitudinally some changes as we help work with community partners to sort of deploy some resources locally?
Okay. If another city wanted to build something similar, where would you advise them to start? Like,
Oh,
what
it's
were like some of the key learnings, like things that maybe you wish
um,
you knew
Yeah, I
on
mean, I think
the
I
outset?
think what I would say is if you have any ideas, like I was just on a call a couple days ago with some people from the New York area, and they have a similar research network with a lot of the hospitals there. And so, I think you don't know what is possible till you ask. So I think, what I would say is be persistent and resourceful. And don't assume you have to build from the ground up. And sometimes people have already done work that are really helpful. And in my case, Capricorn already was a well formed research network that had data, had partners. And so I didn't have to sort of build from the bottom up. And I think when I first wrote this proposal many years ago, I thought I would have to. And so the lesson learned is sometimes the easier way is better. So,
And now you can be a resource for some of these people.
yeah, that would be the hope. I mean, I think our hope is uh, that this could be really a resource not just for the city of Chicago and the communities around it, but also for those other people that work at this intersection of sort of public health and data to sort of think through how can health systems and research networks better serve the community that they are kind of studying and impacting, right? And so this is just one way of doing it.
And there's a lot of potential because we kind of touched on this earlier, but healthcare spent years collecting troves of data. And so to be able to operationalize it the way that you are doing, I think it'll have a huge impact in a lot of places.
Well, that's what we hope. That's what we hope. That's the dream, and I think we're looking forward to it.
If this succeeds the way that you hope, what does Chicago look like 5 years from now?
Oh, I mean, I think this is one piece of the pie, right? I don't think that any one project can solve all the problems we have in any major urban area and as it pertains to healthcare outcomes. But I just think that this is an example that I'm hoping this is a lightning rod, if you will, for people to think, hey, like if someone can do this, maybe I can do something very similar for a different type of disease or a different problem that is related to healthcare outcomes. Maybe it's like building a map. I mean, we have put some of this on there, but like, a map of what are all the resources out there for people to use that are already out, like a food pantry, a clinic, et cetera. We have some of that on the map, but we are, that's, I wouldn't say the main feature of the map, right? So could someone else sort of take what they learned to sort of build a report or a resource for people that is like, in my area, what is available? Yeah, we have some of that on our product, but I would love for someone else to take that, baton and be like, hey, I'm really going to make a wonderful, curated, thoughtful resource that, things open, things close, and make it really resource rich, but also correct. Those are all things that I'm hoping in the next 5 years that this potentially can be a starting point for all these little sub projects that become a coalesce around improving the healthcare outcomes of our patients both at Rush, but also more broadly across the city. And then obviously the big dream, which I think will take longer than just 5 years, is can we use resources like this sort of idea of data to action to create local and then also citywide initiatives and more region-wide initiatives that are really aimed at decreasing those life expectancy issues that we see. And then, in a dream state, if this was just one small piece of the pie, that 10 years from now, we're able to say that the life expectancy is shrunk to 10 years from 19 to 22 or something like that, right where it is now in certain communities, that would be a huge win. If I look back 10 years from now or 5 years from now, that would be a huge win. But really just sort of providing value day to day, right? I mean, we've seen some good engagement with the site already, trying to get the word out through mechanisms like this podcast and others to sort of get people to, play with the data, see it, experience it. I think, what I've learned is that people I can say something in words, but when they can see it in a map, it's more real. And so I think seeing is believing, I think. And so I'm hoping that people go visit the site and sort of experiment with it. And, we have a little contact us. So if you have questions, concerns, ideas for making it better, we're always trying to improve it over time.
I've had a chance to play around in there, and I feel like the user interface is really good. Like it like you said, seeing is believing. It's all right
Yeah.
there.
Yeah.
So
No, thank you. We've spent a lot of time thinking about that user experience. So,
let's switch gears for a quick round of rapid fire questions. Given your AI background, just please the first thing that comes to mind. So, what's one AI tool that you use personally that has nothing to do with medicine?
oh, there's too many to name. Well, I guess what I would say is, I have really gone into this idea in probably the last year, really. I think in December of 2025, when the Opus models came out, I think there was, this whole idea or this joke in Silicon Valley that like all of a sudden all these developers went home and they had a holiday break and they just made projects. And I was just like that same person as I was a doctor doing it at the same time. And that's the first time I realized that, like, with Claude Code as a harness and then a model like Opus and now even better Fable, you can just do things that were not possible for me to do before. Like if I wanted to, I'll give you a real life example. I work in a research lab, wearing some of the hats I didn't talk about today. And I was unhappy with our project management tool. So I just built one over a weekend. Like I never would have done that before. There's no reason I have any business making a SaaS service for lab project management, but I did. Uh, so um, what I would say is, for those of you listening who are maybe not feel like they're not technical, I may have been, yes, before all the AI boom, I did know how to code and touch a computer, but it wasn't that wasn't what sort of got me over the hump. Is really just realizing that right now, even where we have today, the AI, and that's going to change more and more. If you have an idea, now you still need to sort of think about the right idea and who's to use it, but AI can help you get there. It's a vehicle. And so that could be this health map project that we just talked about, or it could be a personal project like, hey, I just want to organize how I work out better. Before you'd have to go, I don't know, Google something, but now you can just work with AI to make something that works for you. So what I would say is, one AI product is probably not enough. I think it's really just, I'm just excited about this idea of having, I don't know, citizen developers, for lack of a better word, where people can sort of build things and maybe solve a really small problem for you. Maybe it's not going to solve a million problems for everyone else, but it just works.
What's one AI habit you wish every clinician had?
I would say, just be curious. I feel like, healthcare in a lot of industries are sometimes, for a lot of legitimate reasons, scared of kind of moving fast, right? And I have a lot of colleagues who think I'm crazy, who think when I type into a terminal and it talks back to me that it's scary. But I just tell people, like, try it one time, come up with something that's a pain point for you, and I would say, I've had sessions one on one with people like, hey, what is a problem that you wish you could solve? And I would spend 15, 20 minutes with them with whatever local AI friend they have. And we're able to sort of come up with at least a starting point. And then my homework for them is, now, next time you have a problem, do it yourself. And so um, for me, it's really curiosity and sort of just being curious and uh, excited about how this could potentially change your workflow for all the things you don't like doing in medicine. There are so many things we do in healthcare that people just don't like doing. They want to spend more time with patients. They want to spend less time typing on a computer. Guess what? Not the only way, but one of the ways that that could happen is with AI, right? So, um, my advice to clinicians is to just experiment and think about how you can use this. And then more importantly, advocate to people like me who have leadership roles at health systems to provide them with tools, right? You can only do this in a safe sandbox. You don't want to have shadow AI where you're using your own AI at work. And so if you're like, hey, I really think this tool is great, phone your local AI champion and let them know, hey, this is something that might really be a great boon for other people, not just me. And then hopefully get that approved.
Last question. What's one healthcare AI use case that you feel is maybe underhyped? I know right now the ambient scribe is like probably the most common use case, but Is there something that you feel is underhyped?
There are a lot of underhyped use cases, but I'll tell you one that's actually happening that we're really excited about. We're in the middle to late phases of kind of an early pilot for something we're calling a healthcare tumor board orchestrator agent. And essentially in healthcare, especially in cancer, doctors meet usually on a weekly or biweekly basis to discuss what they think is best as far as treatment options for patients who have certain types of cancer. And it's a multidisciplinary group, different a surgeon, a medical doctor, nurses, pharmacists, etc., who get together either in person or on Zoom these days and discuss what the best approach. What we realized, which is not unique to Rush, but is unique to having these tumor boards, is that it takes a lot of time for humans to prepare for said tumor boards, right? So for any one patient, if I'm a patient in a tumor board that they're discussing that day, it could take one of the people in the staff somewhere between 15 and 20 minutes to sort of collate all the information from the computer to put together a story that people could digest in a relatively quick way to help make an informed decision for that patient. And so that, to me, when I heard that, I was like, light bulb went moment. I was like, I think AI can help, right? And so we're, in that process where we are sort of taking data from the computer, translating it into something that people can see and iterate and still have a human in the loop. They can take a look at it, make sure there's no hallucinations, no issues. But a lot of that initial fact finding that people do, that ends up being a lot of copy and paste in healthcare, now is solved, or not solved, but at least assisted with AI helping you, right? And then so if we can make that nurse who's putting together a PowerPoint deck, a Word document for that screen that is going to be shared for everyone to see, can we make that take her 4 or 5 minutes, as opposed to 15, right? That's what we're really excited about. So stuff like that. I think a lot of those use cases are, to me, are equally as important, but also a lot of use cases that people are worrying about now are things like, revenue cycle and call center stuff. And not to say that isn't super important too, to make healthcare more efficient in all the other ways that we are inefficient. But I guess as a clinician, I always have sort of a soft part of my, my being, that I really want to help the other frontline people doing the work, because I know that they're spending so much time doing this work and they're trying to do the best job, but can we have AI help them do it, right? And I think it's not to replace that nurse that's doing that job, but just to free their time to do something else that they wouldn't have been able to do without having this sort of AI helper help them put this report together.
Yeah, the back office stuff is always the safest, kind of, especially in healthcare. So it's great to hear from folks like you who are looking at it from the clinical side as well. And I definitely think we should check in again sooner than later. I'd love to hear about more of this stuff. So Dr. Rojas, thank you so much for joining us today and for sharing how your team is helping turn healthcare data into decisions that can improve communities.
Thank you so much, James, for having me.
And thanks to everyone for listening. If you enjoyed today's conversation, be sure to subscribe to the Scopewell podcast wherever you get your podcasts. We'll see you next time.